Freedom Healthworks is the direct primary care accelerator. We help doctors across the country start fresh in direct primary care. With Freedom Healthworks, you work with a team, not a checklist. Visit freedomhealthworks.com and together we can achieve true freedom in direct care.
Hi, everybody. Welcome to Healthcare Americana. I am your host, Christopher Habig, CEO and co-founder of Freedom Healthworks. Today, we're exploring the continued theme of finding alternative sources of care that is quality and easy to understand cost pricing, and you get to work with amazing people at the same time. So today we talk to Dr. Andrew Wickline, an orthopedic surgeon at Genesee Orthopedics and Plastic Surgery Associates out of upstate New York. Dr. Wickline, thanks for joining us here on Healthcare Americana.
Thanks for having me. I really appreciate it.
Now, I want to get a little snapshot from you before we get started into a lot of the broader conversation here. What does your practice look like today compared to where it was when you started some 20 odd years ago?
So, I'm a lot balder and a lot grayer, and practice has become more challenging. Just as with the primary care specialists, we feel it the same in the specialty groups. I'm a hip and knee replacement surgeon. That's pretty much what I do. I do some knee arthroscopy, but mostly hip and knee replacement. And the Academy just put out a paper showing that we are 40% down in hip replacement and 37% down in knee, or maybe vice versa. But in any event,
volume? Is that like number of volume?
No. 40% down in reimbursement. Last 20 years.
I gotcha.
The volume is up because if you're 40% down in reimbursement, the only way, since the prices are set by by a group that doesn't understand what we do every day, prices are set.
Right?
Yes, yeah. Prices are set, so the only thing we can do is do more work. And I'm one of the busiest surgeons in the state. Multiple years I've done the most of this in the state. I'm always in the top 5 for volume. Thankfully, we are able to marry that to the lowest complication rate in the state. The new data just came out, so we're pleased to share that again. But it's troublesome is really the bottom line, which is really why I've been reaching out to look for new ways to do what I do best, which is take care of patients and try to get away from the insurance carrier. So I've been offering self-pay joint replacement at one of the lowest costs in the nation. And that's how I actually came across your company.
We love like-minded people all over the country, and as we continue to expand in states, we relish conversations like this. And what I always tell people is Dr. Wickline, you're not alone. I mean, this is something that's taking off across the country. There's here in my hometown of Indianapolis, there's like-minded surgeons and anesthesiologists who are doing the exact same thing, and it's really amazing to see. And you have to say, well, wait a minute, I thought all these doctors were happy, right? If you're a patient on the street and saying, well, I don't understand anything to do with insurance, and I figured that this was all just the way it works. But what are you seeing when you tell people that I have a cash price that's this? And I mean, is that going to be significantly cheaper or on par with insurance? How are those adding up?
So, my cash pay price, it's clearly written on my website at andrewwicklinemd.com. It's $16,800 for a total hip and $17,800 for total knee. That includes everything: the surgery center, the anesthesia, the special pain medications that we use. Additionally, it includes, I developed a protocol for no therapy, and I think I'm sure we're going to talk about that at some point, but essentially that saves patients another $3,000 minimally post-operatively and less pain. So it's a very fair cost. When you look at the recent federal guidelines that hospitals have to post prices, you're seeing $44,000, $50,000, $98,000 out in Sutter, California. I mean, there's no reason for it to cost that much. And I think it's criminal that these prices aren't posted. We should post prices, and there should be fair reimbursement. Um,
And
we
stick to the
talked
prices too,
briefly
right?
before. We talked about this briefly before. Let me just ask the audience who's listening, and then you can give me your number and try not to cheat. But what do you think I get paid for a knee replacement? What do you think the average person thinks I get paid for a knee replacement?
Based on the numbers you just threw out. So if you're doing, an insurance company would you say about 40K at most hospitals out there? I bet, and because I have some family who are ENTs, and they tell me their reimbursement margins based on just simple putting tubes in the ear. Um, Based on insurance one, I'd be shocked if anybody out there said that you make less than $5,000 on a typical replacement.
So you're way off base. I get $1,341 for knee replacement, and that's from Medicare. So the commercial payers pay another 20% on top of that. And there have been multiple studies suggesting that patients think we get $8,000 to $13,000 for joint replacement, and that's just not the case. So, $1,300 minus 60% overhead minus New York State taxes of 46%. That's, I don't know, $237 in my pocket to fix your mom's knee. So, I don't like it. I don't like fighting, and then I have to fight to get that money. So, I want a fair reimbursement. We ask for it's a $3,000 surgical fee. We do this Iovera. That's where I freeze the nerves preoperatively for the knee. That's $1,500, but I know it works. I've had all my family members, have it. It basically freezes the nerves for 3 months post-op, helps with post-op pain. And with my protocol, we've also published lowest in the nation opioid usage through 90 days. We are 5 times lower than the next best paper at a Mayo Clinic. So my patients use 10 pills or less through 90 days, and that's just unheard of. The average is 150 pills. So,
wow. Yeah, you mentioned, I want to unpack and dive into a couple of different things that you've been mentioning here so far in our short conversation. You mentioned that you have the best, I guess, lack of complication rate. Was that the state of New York, or was that
yep, state of New York? That's
state of New
CM.
York? So describe that a little bit and what goes into that and where those metrics come from, because to me, like, that is the definition of quality medical care. And I know that a lot of people have different definitions of the Q word, as we call it, and it's usually whatever insurance companies tell a hospital or a physician is quality based on a bunch of different numbers. But I'm thinking complications and outcomes is a great judge of quality.
Yeah, so you're right. It's very challenging to figure out. It's a moving target, right? So, CMS publishes some data. They look at 90-day readmission. They look at 30-day readmission, and then they look at the reasons for readmission. So they publish that data. So for our hospital, we were 1.6%, which was the lowest in the state of New York out of 101 hospitals that met that certain volume criteria. And my personal number is 1.1%. I do 80% of the work there. So, I was the driver of that number. And then we published that data separately in a separate study. Again, that opioid study showing that, our rates, it hovers between 1.1 and 1.2% per quarter. Alternatively, if you want to look at it a different way, I was also involved with the federal government's BPCIA plan, which is it's a bundled arrangement where you look at cost over 90 days, and I have one of the lowest costs in the entire nation. And and that looks at readmission, right? Every time you have a readmission, that's a $20,000 to $80,000 cost per patient. So I went at risk. I could potentially have owed the government that money, but instead, I was rewarded for doing exemplary work. And so there's 2 different ways to prove that the complication rate is what it is. There's multiple studies showing, there's one of the big centers down in the city, they have about a 5% complication rate in their BPCA data. And, there's a big difference, and that's where that's what drives cost, is complication.
So the next thing I wanted to touch upon that you were talking about was the therapy-free techniques that you're using, because I shared this with you kind of offline, but I did my time as a financial analyst intern at DePuy Orthopedics up in Warsaw, Indiana, manufacturing joints and all kinds of cool stuff. And this was way back when, but great people, loved it. And every once in a while, we'd get the pleasure, I guess, of sitting at the desk and watching the latest DePuy Orthopedic product being put into somebody's leg or hip. And I'm thinking, this is hard to watch. You got these guys just pounding these legs in, pounding these knees in and the hips in. And I just don't think a lot of people understand what goes into a hip replacement, and it looks painful. And that's the reason I bring this up. I mean, this looks painful, major surgeries here. And then you're able to develop this this new technique, this new system that you just briefly mentioned. So expand on that for us and say, here's what most orthopedic surgeons do, here's what I do, and here's how this is more beneficial.
So most surgeons use the techniques that they were taught in residency and fellowship, and that's what's worked well. And so that's what they do. And you go to a meeting or two and, it kind of confirms, yep, that's everyone's still saying the same. But it's very hard to leave the fold of convention because what could happen, right? It's scary to do something different. So most people will do a knee. Let's just say with knee, hips are easier. And after therapy, the patient will then, or after surgery, the patient will go to therapy 3 times a week for about 6 weeks, sometimes as long as 12 weeks. The academy says it takes 10 to 12 weeks of going to organized therapy 3 times a week to get 110 degrees of motion. In our paper we published, we were able to see 109 degrees at 3 weeks with 85% of patients using no therapy. So if you look at it, just the copays alone, let's just say $40 a week, a session. So now you're at, what is that, 80, 120 a week. I mean, now you're looking at like $700 of copay money for 6 weeks of therapy, let alone what the insurer is paying. So on average, it's about $3,000 for post-discharge spend in the therapy space. And it's miserable. So what we do is I teach my patients how to do some simple exercises, and they do it a little bit each hour, and it's much less painful than 90 minutes 3 times a week. And I feel bad for the therapist because the way the billing is, like, they feel like they have to beat on the patient. And that's how you get into this crazy cycle of needing opioids before and after therapy, and then it hurts so much I can't bend. And by the time the swelling goes down 36 hours later, it's time to go to therapy again. And so many of my therapists in the town, they were very angry with me at first, but many of them now have kind of switched to a more less aggressive approach. Strengthening should not be done straight out of the gate, but that's the way the billing system is set up in the United States. So really, you need to work on range of motion and controlling the swelling.
Sure. And I'm just curious about compliance rates, because when I hear, people are chasing top dollar, which is a natural thing for us to want to do, right? Human beings are wired to take the path of least resistance for the greatest outcome. Were people following through on the traditional surgery, still going to all 12 therapy sessions through the pain, through the, potential pill addiction? I'm just curious to see what the compliance rates were, and then if that led to any more complications down the road.
So I definitely think that the 90-minute work, if you sprain your ankle badly, do you go and do a 90-minute workout the next day? No, right? It's going to swell. It's going to be miserable. We've all learned this lesson as a teenager. We learned that lesson. And so, but what are we doing with the total knee? Just like you said, I make a cut. I hit you with a hammer. And it takes an hour of beating on the patient, and then sew it all back up, and then tell you to do lunges and squats. That's crazy. And so, basically, I listen to this is a customer service profession. You listen to the customer. The customer comes in and says, "Doc, I love my new knee. Finally, at 3 months." And I say, "Okay, when are we going to fix the other one? It's terrible too." "Doc, I'm never going to have that one fixed because the therapy was so painful." And again, it's not because the patients or the therapists were trying to be mean. It's just that they felt that this is the way it's always been done. So this is what we have to do it.
Mm-hmm. I love the vocabulary you use. You called somebody a customer. All too often, what we see is that there's a hesitancy to call a patient a customer we like to use the word, consumer, but that's really what it is. So, I'm right there with you on people being customers and having that customer service experience be something that they want to come back and do again. And then, you throw in the opioid epidemic and how what you're doing is helping alleviate that problem. Because I mean, you can totally follow the breadcrumbs here. You have a very major surgery, you have pain, you have painful therapy, you take a pill, you have another painful therapy, you take a pill, and it just kind of drives onto itself, right? So,
Correct.
in my opinion, and I would assume that people are very happy coming to see you, and sounds like great quality outcomes. I mean, am I on the mark there?
Well, I mean, again, so the customer is always right. And the customer says the therapy is torture. I don't ever want to do the therapy again. You have to reassess that. So that's what I did. And I created a protocol that you just do 5 to 8 minutes per hour of simple bending and straightening exercises. You do that for the first 2 weeks while the swelling's terrible. And lo and behold, by 2 and 3 weeks, you get to motion. And now you get your life back so much quicker. And that just improves a whole number of things, less DVT risk, less opioid use, right? And so again, like you said, you have to listen to the customer. When the customer comes back and says, everything was great except X, Y, and Z, you start plugging away on X, and once you fix X, you fix Y. That's really, I think that's what's driven. That's why we do, routinely we're in the top 5 for volume year after year for joint replacement. And I'm in Utica, New York, a little small town. We're not a big city.
I want to shift gears and talk about, what you mentioned before about transitioning from the insurance and Medicare model into the cash pay type of a business in care model. And for once again, these listeners out there, we're talking to Dr. Andrew Wickline, an orthopedic surgeon at Genesee Orthopedics and Plastic Surgery Associates. So Dr. Wickline, looking at the cash pay environment and cash pay ecosystem out there, and I know that's how we got connected, from Freedom Healthworks and, from a podcast standpoint as well. What have been some of the biggest challenges? Well, let me start with this question. What has been your biggest motivation into getting away from insurance and switching completely into the cash pay realm? Listen, learn, know. Healthcare Americana is a podcast for the 99% of people who get healthcare in America. We're not clinicians or policymakers. We're patients and caregivers, executives and advocates who are fed up with the status quo and have a desire to change it. We produce a weekly podcast that brings listeners backstage at innovative organizations across America that are putting patients first by delivering exceptional care to anyone and everyone.
Well, I have not divorced myself yet from the commercial payers, but I'm looking to do so. They're not a partner with me. Again, we talked earlier about this cryoablation, this freezing of the nerves preoperatively. It's not super expensive. It helps reduce post-op pain. And why shouldn't we be doing that? And it was covered by Blue Cross Blue Shield here locally, but then they decided not to cover it. I met with them and they told me, oh, you're already at the lowest opioid use. So what's a few more opioid pills? You're already lower than everybody else. And
what?
Yes, that's exactly
they
what
said,
they told
go
me.
ahead. We don't care if you throw some more pills at somebody.
Yes, they said you're already at the lowest number. You've already told us this. You published it. So why would we want to pay for this? And I can't fathom that. That's criminal in my mind.
Why would they? Yeah. Why? What's their even motivation that they want you to bill more or what?
Yeah,
I'm at a loss. I have no idea.
Yeah, one 24-hour prescription of opioids is associated with up to a 6% risk of permanent addiction. If you become permanently addicted, you double your yearly commercial pay cost. So a commercial payer typically pays just under $10,000 for each patient, and they take in $18,000 per patient. So they're already making a $9,000 profit. But those opioid addicted patients, it doubles. It's $20,000. So now they're not making any money on that patient. So why not prevent the opioid problem in the first place? For $1,500, again, the data is there. They said, no, you don't have enough data. I said, okay, why don't you why don't you pay for a research assistant? I'll get you the data so that I can help prevent opioid addiction. And they're not interested because it doesn't help them make money.
That's incredible. I mean, I'm rarely speechless, but I
They
have no idea what to say to that. I mean, that just doesn't, it just flies in the face of everything.
they told me they
You know,
had their internal experts review it. And I said, well, why didn't you ask me? Clearly, I'm an expert. I published on it. And again, no interest. So it's very, this is why I'm moving away from that model. I want to have clear pricing. I don't like this hidden in the dark pricing. I want a fair price. I'm not asking, for $10,000 or $12,000 to do the surgery like down in the city or other places. I
mhm.
just want a fair price so that my staff all want raises. And the only way I can get them a raise each year is to do more work. There's a finite number of hours in a day for me to work. I want to be fresh and good for my patients. And so I just have to keep taking a pay cut every year so that my staff can at least have cost of living raises. So the only way I can see out of this is to divorce myself from commercial payers.
Well, spoken like a true business owner, right? You're going to be the last one getting paid. You're going to make sure your team, your staff are taken care of, and everything's going. And then if there's anything left over in the kitty afterwards, after everybody's taken their cut, like you're talking about earlier, then
Yeah,
that's going to you, right? Like I
yeah.
said, big if on that one. So I think I think you've made a great case for your motivations on kicking insurance companies out of your OR. What have been your biggest challenges? Let's go there. You know where you want to go. You know what you want to do. You know why you want to do it. You know how you can do it. What are
I
the
don't
roadblocks?
the roadblocks. I don't know how to reach my direct primary care providers. There's no national network that I can get on and say, here's my website, here's my portal. As we talked offline, and in 6 weeks, I hope to have all of the, at least sports medicine, as well as plastic surgery and hand surgery. I hope to have all of that on board with clear pricing at my surgery center. And we'll be the first in the Northeast, in all of Northeast that I'm aware of, to do this.
Hmm.
Um, and so I think that makes sense. But it's that in and of itself is a problem, trying to get all the different people to figure out what their actual costs are. And this
Right.
is why I think hospitals do have a problem with this. It's hard to, it's a moving target. The next issue is, again, like we talk about, getting in front of potential customers. Hey, this is what we do. Here's my quality metrics. How do I get in front of them? I've done some Google pay stuff. I've reached out to networks like yourself, and I do podcasts, but I don't know how to connect with providers and with patients so that I can do what's necessary for the patient and get them back to work and everyone happy with the cost.
Do you find that, the patient, the customer, as you termed it, do you find that they're the ones calling the shots on that, or are they beholden to like an employer plan or another health plan that's trying to influence them one way or the other?
So I've had a number of patients. So like I said, I practice in just outside of Utica, between Utica and Syracuse. I mean, pretty much we're right on Route 90 and just shy of Route 81. And I've had patients from North Carolina. I've had patients from Maine, Ohio, Pennsylvania, Connecticut, Canada. So we have patients who make the drive, and on the website they talk about it. It was worth it. It was definitely better. I have an education booklet that talks about every single day post-op, what's normal, what to expect. Nobody provides that.
Right.
So I, it's just, I just find the patients are stuck. So I have a patient, I don't want to use the name of the company, but they have a big cost sharing company. That company didn't have a list of provider specialists. And so he had to go online himself and poke around. And thankfully, because I've been doing this long enough, it came up high enough on the Google search engine that he found me. And now I'm going to fix his other knee and his wife's knee. And the same thing with my lady up in Maine. She's a direct primary care provider, and she was looking and looking. And then it just happened the last time she looked, I had finally gone live with the self-pay, and this was So I've done both of her husband's knees, and I think her knee's coming up in the fall. So it's worth the drive for them. We have a way to make that work. And because you don't need organized therapy, and you don't need lots of this extra accoutrements that I think many providers still think you need, we help keep it streamlined.
Right.
But I agree that the providers and there's way too much infrastructure that kind of direct patients, and they're directing them in the wrong places.
Yeah, absolutely. And that's why I was curious about that. And that's something that I think we could all be better off, or better about being more intentional about it, even those in the DPC world and the direct care world. Is all too often it's kind of our default to go back to those bad habits of, oh, okay, my patient needs a knee replacement here. Go talk to this, orthopedic group in town. Good luck. Let me know how it goes, type of a thing, right? And that's a lot of the bad habits that we're always encouraging physicians to break. Is let's not rely on the insurance, your patient having insurance and using insurance out of the office. If they're used to using cash, let's find the right type of options for them. And I know that's something we've been working very, very hard on, and we're super close. We're so close to being able to help stitch together the specialists and the surgeons and all kinds of stuff across the country. And it's great to talk to people like yourself who are like, yes, that's what we need. Create that referral network of cash paying smart consumers, smart healthcare customers, and keep them in that system, and don't let them go back to the evil hospitals and the confusing insurance plans. So, I think you being right there and the same type of wavelength as a lot of the physicians are around the country.
I, I like these
People are going to be
patients.
benefited. They're going to benefit from it.
These patients, because they're doing their own legwork, trying to find a surgeon that, number one, does cash pay, and then number two, now they're actually okay. Now I maybe have got 3 choices or 4 choices. I found 4 people maybe. So now okay, well, I don't know any of these people, and the only way I'm going to figure out if they're good or not is I've got to look online. What are their metrics? So this is already a patient that is involved in saying, I want a great outcome, compared to a patient who comes in and the doctor said, yeah, you need it, you're walking poorly, go see the hip surgeon. And you see that patient, and that patient doesn't want to read the book, doesn't want to get educated in understanding how they can improve their own outcome by making some minor modifications pre and post operatively. And so not only do I love being away from the insurance company, these patients tend to be they're just self-motivated to get better. They own their own business and they need to get back to work. They're not, I was in a car accident, so even if I am better, I have to pretend like I'm not better because the way the insurance industry is, I can make some money off of this. I have trouble dealing with those kind of patients.
Because people are not assembly lines. And so when you talk to doctors about, I need to see 40 patients a day, and you talked about, I need to do X amount of cases. When you start getting into that mentality, to me, that's a very slippery slope, because I'm approaching it from the patient side saying, well, is this doctor even going to know my name, or am I just patient number 35 today at the end of the day that's been hellacious? And that's very scary from a health standpoint, because we're all different, right? tell me if you've seen one need that's exactly the same as another one out there. Everybody's just a little bit different, and that's very scary when we try to commoditize medicine in general.
Yeah, I agree. I limit. I made it a long time ago. I said, I'm never going to do more than 10 surgeries in a day. That's the max. I want to be done by 3 o'clock. I want to have a regular 7 to 3 day. That way, all my team's happy, my staff's happy, and that forces the maybe a day that during the week that tends to be a little lighter to be even keeled as well. And that's a better way to have a happy, work home balance, is to you have to set a limit. This is my limit, and that's that.
Yeah, in that scenario, I think the patients will win too, because 10 to me sounds like a lot, but if you're telling me, hey, some people do 30 out there or 20, whatever it is, I'm going to say, wow, I'd hate to be the last person on that roster for somebody working, doing 20, 30 cases a day.
No, generally our last case of the day starts at 1:40, 2 o'clock. Maybe it's maybe a little longer if there was an emergency that shut down a room, from the ER or something like that. But I think everybody's on the same page. Everybody wants daylight surgery. You look at a lot of these universities. The scheduled cases, the 4 scheduled cases, and the last one's getting done at 8 o'clock at night. First of all, it shouldn't take that long. Number one. Number two, does anyone want that team working for the last 12 hours or 16 hours? Nobody wants that.
Right. Right. Well, Dr. Wickline, I'm going to give you the last word here as our discussion draws to a close. Where do you see kind of a big picture based on your experiences? And I love to ask this question. And so I bet some people out there listening kind of roll their eyes like, oh, here we go again. What's the day perfect? Where does the healthcare go from here? Look into your crystal ball. What do you see? Where do you see us going? And does that match up with what you would describe as this is the perfect way to build a healthcare industry?
Ooh, I don't know if you want me to answer that. I don't see this going down a very good road. It's $1 trillion industry, and it's run by 5 large insurance commercial payers. They have a lot of sway, and they help politicians get elected. And so I don't, and politicians like that job. There's power there, right? I mean, it's power. I don't want to say corrupts, but that's what the saying is, right? And so it feels good to have some power, and okay, I guess I can vote this way or vote that way. I mean, I have to believe that happens, or otherwise we wouldn't be in this mess. We need to make those. If you're going to have someone process paper and try to keep costs down, it really should be a net zero company, and it should not be shareholders. I see this in industry from the implant side as well. I see where CEOs are there from 5 to 7 years, and so it makes more sense to build a robot and make those joint replacements. That robot is only good for one kind of joint replacement, and then you don't have to change the joint replacement. And now you can forecast exactly how many cases are going to be done because the hospital's bought into that. And the CEO is there for 5 to 7 years, so they have a short window. They have to keep the shareholder price up. If they do, they get a nice big bonus when they leave. The whole healthcare system needs to be taken out of the market. That is the biggest thing that I see. And I hope that some politician hears this and makes this their crusade, because you cannot allow these decisions to be made by, these decisions are all based on shareholder price, not on outcomes for patients.
Mm-hmm. Mm-hmm. Well, there we go.
So I have a very dismal outlook on that. Sorry to say.
Well, that's all right. To me, that says that anybody listening there, especially physicians and people in medical, need to get involved, grabbing the ear of their politicians and their representatives. I mean, that's something that we've always encouraged. Is I think too often physicians will take a back seat and saying, well, I don't want anything to impede my clairvoyance, my medical judgment out here, whether it's market forces or business forces or political forces. And then if they're not going to be involved, somebody else is going to be. And that's kind of, to me, what you were saying is how we got to this path is the people who are wired to take care of other human beings, God bless all their souls, they took a back seat to other people who stepped into that void and have the ears of the policymakers. And that's a serious problem.
I've tried to meet with Senator Schumer and Gillibrand. That their office has reached out to me. Well, one of the offices reached out to me, and I was able to talk to a very, very junior staffer. But that's as far as it gets. There's no interest because I'm not helping obtain a re-election. I hate to say it, but I have lowest opioid use in the nation, Chris. I mean, come on, lowest opioid use in the nation and no therapy. If the entire country did my protocol, and I only got 85% success with no therapy. So let's just say it's only 85%. That's 850,000 total knees times $3,000 each. That's $2.5 billion savings per year.
You take that to the bank all day long, right? Like that is actual provable numbers.
Tell me why I can't get a seat with the senator.
Yeah, you think that somebody's antenna would raise at that one and say, "Oh wow, here's actual solutions." They don't fit any talking points, neatly, but here's actual real world solutions that we can do some good with. Well, Dr. Wickline, thanks for joining us here on Healthcare Americana. Love what you're doing. We need more of you, so keep up the good work. And then if anybody out there is listening and say, you know what, I have some patients or I have a need for another resource for great outcomes, great quality care at a price that we can all understand and see, AndrewWicklineMD.com. Best place to reach you?
That's the easiest way you can get an appointment that way. And again, you can look at my data, my published studies are on there. And I really appreciate you guys having me on. We need to get this word out to regular people, because the only way this is going to change is a grassroots, non-representative movement to get a law that changes this. Thank you again for having me. Really appreciate it.
I'm right there with you. Dr. Andrew Wickline, orthopedic surgeon, Genesee Orthopedics and Plastic Surgery Associates. Once again, I am your host, Christopher Havik. Thanks for listening to Healthcare Americana. To check out all of our past episodes, visit healthcareamericana.com to check out all the fun things happening in direct primary care and direct care and even cash pay surgeries as we continue to empower physicians to take back healthcare. Visit freedomhealthworks.com. Big thank you to Taylor Scott, iPadcast Pro, for their editing, and Melissa Turpin for managing Healthcare Americana. Thanks for listening. Hi again, everyone. This is Chris. At Healthcare Americana, we're always on the lookout for great stories to tell in the healthcare industry. And we'd like to hear yours. Check out healthcareamericana.com and send us your ideas for episodes or if you'd like to be a guest. Thanks again for listening. Hope you enjoy it.